మనం ఇంతకు ముందు అనుకున్నాం చూడు.
డబుల్ షేరింగ్ ఇంకెవరు రానే రాలే.
వస్తారు. విజయ్ కిరణ్ అంటారు. పోస్ట్ నేనే కదా, ఇది కూడా జాయిన్ చేసేస్తే నంబర్ ఉన్న చూడాలి. 8 ఇది వచ్చినప్పుడు కోవర్స్ చేసేస్తే అయిపోతుంది. మళ్ళీ ఇక్కడ మన రైట్ క్లిక్ చేయమన్నాడు కదా, ఇక్కడ చేసేస్తే కోహోస్ట్ అయిపోతుంది కదా. కదా ఇక్కడ
ఏ పార్టిసిపెంట్ ని కోహోస్ట్ చేస్తాను?
నన్నే కోహోస్ట్ చేసుకుంటాను. రైట్ క్లిక్ అన్నాడు కదా,
లేయర్ మీద రైట్ క్లిక్.
మొన్న చూసాను నేను, ఇక్కడ మోర్ మీదే వచ్చింది.
డబుల్ ఎందుకు అన్నావు?
ఇప్పుడు నేను ఇక్కడ హోస్ట్ అయ్యాను. హలో రెండు ఇద్దరిని కూడా చెయ్యొచ్చు ప్రసన్న, ఒక్కరు కాదు. వాడిని అడుగు, యూ కెన్ మేక్ 2 people.
Hello. Hello.
We'll make this.
Sir, వినిపిస్తుందా?
Yeah. వినపడుతోంది.
Okay.
Vijay, you are audible to me.
Yeah, nice, sir. So, sir, how should I upload my slides?
You have a computer now on the computer.
Yeah.
You upload and share it. Share screen మీద చేయండి.
Okay, yeah, share screen అని ఉంది, correct. Host disabled attendee screen sharing అని ఉంది. I think you have to enable it.
I have enable the I have to enable screen. Sir, ఇక్కడ నుంచి చేద్దాం. ఇక్కడ పోస్ట్ అయినా కదా.
చూడు ఇప్పుడు వస్తుంది.
సార్ అది
నీది
అట్లా కదా. I have to enable him.
చేసినావు కదా. షేర్ స్క్రీన్ ది డాడీ అందరిది ఇచ్చేసేసిండు. దాన్ని ఓపెన్ చేస్తే ఆ సార్ ఆయన స్లైడ్స్ షేర్ చేస్తారు. ఇప్పుడు ఎనేబుల్ షేర్ స్లైడ్ అని వచ్చిందా? డాడీ హ్యాస్ మ్యూటెడ్ ఇట్. డాడీ హోస్ట్ కాబట్టి.
హలో లక్ష్మణ్ సార్. యా సార్, మీది ఏమైంది సార్? విజయ్ కిరణ్ మీరు చూసారా? ఎనేబుల్ అయిందా?
చూస్తున్నా.
షేర్ స్క్రీన్ లో
లేదండి, ఇంకా స్టిల్ హోస్ట్ డిసేబుల్డ్ అని వస్తుంది.
ఒక్క నిమిషం చూసి ఇప్పుడు చూడండి సార్.
Yeah, I could see.
Yeah, sir.
Can you see the slides?
Yeah, I can see the slides.
Okay, fine. Yeah.
We'll wait for a minute.
No issues.
Yeah.
I'm just concerned whether I can share it or not. That's it.
Can we make second post also? Recording naming. YouTube link and bonus and I asked you 100 times how to generate YouTube link. How do you convert back to this again? Sir, Laxman sir.
Yashwanth, am I audible?
Yeah, you are audible to me.
So another 4 minutes.
Yeah, already Vijay Kiran has joined us. He's seeing the slides.
Yeah. Dr. Mehul Shah ochada connected.
He is about to.
पता लगा तू बेटा आए हो कॉल वाया ऑडियो ईमेल लगाएंगे अब आ रही है
ना फोन ही होगा
उधर
सोनी फोन आईफोन अక్కడ ఉంది బయట
अरे भीमा लॉन्चिंग बोल कर दियो ना भीमा वो लॉन्चिंग की बता दी माँ तो मस्त आ गया Please click open Zoom meeting if you see the systemic darling. Launch the meeting. जरा इसी डाल देना प्लीज कर दे यार
స్క్రీన్ ఎట్లా వస్తుంది స్టక్ అయింది
అదే షెడ్యూల్ ప్రకారం ఉంటాయా లేదా అని ఒకటి తెలుసుకో నాకు మరి రేపు డీటెయిల్ కావాలి మళ్ళీ ఉంటే పైన సోర్స్ ఉంటే మాత్రం కంపల్సరీ చేయమని అరే రేపు
రికార్డింగ్ చేద్దాం అది రికార్డింగ్ Laxman sir, start.
Yeah.
Please, Laxman sir, your opening remarks.
Yeah.
Good evening to President PATS, Garlapati, Laxman, the dynamic Yashowanth Rao of General Secretary of PATS of 2020. So we are having epidemics of academics, pandemics, COVID. So today we are fortunate to have two eminent speakers in the field of pediatric nephrology. One is Dr. Vijay Kiran and another one is Mehul Shah from Little Star Hospital as well as Apollo Hospitals. The first is we will be having a talk by Dr. Vijay Kiran, who is Assistant Professor of Pediatric Nephrology at NIMMS, Hyderabad, and holds MD Pediatrics, DLV, DL Nephrology, and also he trained in UK and fellowship in Pediatric Nephrology. So he is going to enlighten us the renal tubular acidosis in children, which are sometimes we see in children in the form of failure to thrive, or sometimes in the form of polyuria, polydipsia. So it is very important to know what are the clinical scenarios, so that we will be able to diagnose these children in the periphery as well as in the highest level. So without wasting time, I request Dr. Vijay Kiran to go ahead with his presentation. Thank you, President Garlapati Laxman and Yashowanth Rao, for giving me this opportunity to moderate this session today. Thank you very much.
Sir, Laxman sir, with your permission,
Sir.
I'll introduce Vijay Kiran.
Yeah.
Dr. Laxman, Dr. Vijay Kiran did his MBBS in Medical College 2004. Did his MD Pediatrics from SV Medical College Tirupati. Then completed his FNB in nephrology from St. John's Medical College 2010. 2014 he completed his DM from Nizams, followed by DNB nephrology in 2017. And since then he has been working as assistant professor at Nizams. So your attention to Dr. Vijay Kiran.
Yeah, good evening, one and all. I hope I'm audible.
Yeah,
fine. So let us start with the topic of today's webinar, that is renal tubular acidosis.
Please mute all the participants, please.
Yeah. So what I'll be trying to do here is to declutter some of the myths and of this renal tubular acidosis. I'll try to simplify it as much as possible. Who present to us in such scenarios, a very malnourished or a child who is not growing well, or some children who have grown well but still having certain issues, either they're having bent bones or some other problems. These are the common presentations by which children present to us. And the basically how we proceed is that what is sir, I think there's a disturbance from one of the side. I can't. Yeah. So the first question what we will be asking ourselves is, what is the birth of this child, and if the child is small for gestational age or not, because we have to identify what is the reason. We have to identify what is the reason for this failure.
Secretary sir. Secretary, please, you are muted, Vijay Kiran. Nobody is hearing. Please, lot of noise. Secretary, Yashwanth Bhaiya.
Hello.
President ji, please mute all the participants except the speaker. Okay, please see that. So a lot of disturbance is coming. Vijay Kiran ji.
Yeah. Am I audible, sir, now?
Yes, you are audible, Dr. Vijay.
And can you see my slides?
Yes, sir. Yes, we can see.
Yeah, okay, so fine. So let us proceed. So whenever a child with a failure to thrive presents to us, the first thing we have to keep in mind is common things are common and uncommon things are uncommon. There is a very good saying in medicine that when you hear hoof beats, think about horses, not zebras. So the first thing which we'll think about is the various other causes for failure to thrive. That is whether the child was born prematurely, or the child is small for gestational age, whether the child is breastfed adequately or not, is having any chronic infections or any congenital malformations, or any signs of malnourishment associated with some vitamin D or vitamin deficiency, which will all point to a factor that it is usually a non-renal cause for failure to thrive. Once we rule out all these causes, then if at all we are left with certain causes, then we have to think about renal tubular acidosis. But keeping in mind all this workup, we have to be little diligent about certain subtle clues. For example, if the mother says the child is passing excess urine or drinks excessive water when compared to the siblings, or when the child is sleeping, the child is having excess tachypnea, or the child prefers to eat excessive salty foods, that is the chips, kurkure and lays and all these things, and there is mother has noticed that the child has bending of bones and there is hypotonia of the muscles, there is difficulty in looking at bright lights associated with azotemia, then we have to keep in mind there's something wrong with the kidneys. So what we usually do when a child with failure to thrive comes to us, we go ahead with a complete workup. We also quantify the urine output. We ask the mother initially and then ask her to quantify. The first clues which we see in all the blood tests are hypokalemia and hypocalcemia. Because we usually, most of the times, we don't order special tests in the first setting itself. Once we have certain clues that this underlying etiology, about the underlying etiology, with the help of hypokalemia, and then we ask for further tests. That is blood urea, serum creatinine, and ABG, and parathyroid hormone, and ultrasound for nephrocalcinosis. So these are some special tests which help us to identify the reason for failure to thrive, being the kidney disorder itself. And also we have to ask for specialized tests like urine for glycosuria and anion gap, which I will be discussing it. Now, immediately we can easily get an ABG nowadays. Everywhere it is available. Once we see the ABG, or even if ABG is not available, we can go ahead with venous bicarbonate. So in that, if there is a normal anion gap metabolic acidosis, which is usually compensated with the respiratory component of respiratory alkalosis, which is in a layman term called as Kussmaul's breathing, then that finding is very pathognomic of renal tubular acidosis. This is how we usually approach these cases of hyperchloremic metabolic acidosis, also called as normal anion gap metabolic acidosis. So you have to determine what is the net urinary charge. But most of the times, getting the urinary sodium, potassium, and chloride on a spot sample, getting it done, again requires a specialized laboratory. So what we usually do is, in history itself, we rule out whether the child is having diarrhea or not. That rules out the one of the major cause for metabolic acidosis in children. Then, if it is normal anion gap metabolic acidosis without any history of diarrhea, we keep in mind that the child would be having renal tubular acidosis. Mind you that renal failure, that is where when the kidneys are failing, the normal anion gap metabolic acidosis converts to high anion gap metabolic acidosis. So normal anion gap metabolic acidosis without diarrhea, we can directly go ahead and label it as renal tubular acidosis. Now we have to ascertain whether this renal tubular acidosis is due to a proximal convoluted tubular disorder or a distal convoluted tubular disorder. If it is something associated with proximal tubular dysfunction, then we can easily label it as proximal RTA. I hope I'm clear. If the proximal renal tubule is absolutely normal in certain tests, which I will be highlighting, then we have to go ahead and measure the plasma potassium levels and then take it forward. So metabolic acidosis is usually associated with a compensatory rise in ammonium production in the body. This ammonium production occurs where it occurs in the kidney. Now, in renal tubular acidosis, this ammonium production comes down. Hence, what happens is these patients will become acidotic and the urinary anion gap will become positive. Now, this was a paper which I have published in Indian Journal of Nephrology a few years back. So this is a complete clinical profile and outcome of renal tubular disorders in children. We have noticed that the most common renal tubular disorder, which we usually see in clinical practice, nearly 44% of the times is distal renal tubular acidosis. Renal tubular, that is distal RTA, which is next followed by Bartter's and other like proximal RTA. Isolated proximal RTA is very uncommon and usually presents in the form of Fanconi syndrome, which I will be discussing in a little bit detail over here. So basically, we should understand why early diagnosis and treatment is essential. In this study, we have noted that when these children were identified earlier and treated with the correct bicarbonate replacement and potassium replacement and constantly followed up, keeping their values in the normal range, it was seen that they grew well and almost they attained their peers height. So early treatment will cause the growth to increase, the child height and weight and whole growth will increase and it will lead to a good quality of life. Now coming to a little detail about the proximal tubule and the distal tubule. Any disorder of the proximal tubule will lead to proximal RTA. Any disorder of the distal tubule will lead to distal RTA. So the different types, type 1, type 2, type 3, type 4, these are all complicated terminologies. Distal RTA is again nothing but type 1 RTA because it was identified first. Proximal RTA was identified later, called as type 2. Type 3 is something in a mixture of these two, but nowadays it is no longer used. Type 4 is something related to the renin and aldosterone system, usually seen in adults with diabetes. So how does our proximal tubule function? Have a look at this slide. The proximal tubule helps in phosphate reabsorption. If something is wrong with the proximal tubule, phosphate gets lost in the urine. And phosphate is one of the components of the formation of bones. So calcium is a brick, phosphate is the cement. So if phosphate is lost, that will lead to hypophosphatemic rickets, number 1. Number 2, proximal tubule reabsorbs glucose. If something is wrong with the proximal tubule, that will lead to renal glycosuria. Similarly, amino acid is also lost, lead to isolated or generalized amino aciduria. And coming to the topic, today's topic, that is bicarbonate, because nearly 90% of the bicarbonate which is filtered has to be reabsorbed in the proximal tubule. If there's something wrong with the proximal tubule, the bicarbonate is not reabsorbed, will lead to proximal renal tubular acidosis. Now look at the distal tubule. The similar thing happens. Something is wrong with the distal tubule, either a genetic or an acquired cause, which will lead to distal renal tubular acidosis. So these are the two etiologies which we are going to discuss today. In proximal renal tubular dysfunction, these are the two main disorders, that is proximal RTA, hypophosphatemic rickets. Today I will be talking about proximal RTA, not hypophosphatemic rickets, because that forms a completely different topic and we can discuss it maybe in the future in the topic of rickets. Now let us see what happens in the proximal tubule. See, from the glomeruli, most of the bicarbonate is filtered off, and this bicarbonate, when it comes to the proximal tubule, it has to be reabsorbed. So for reabsorption of this bicarbonate, the main enzyme which is used is carbonic anhydrase. This is where our carbonic anhydrase inhibitors, that is acetazolamide, all these things act. Okay. So once the bicarbonate has to be reabsorbed, then the acid, that is the base, is reabsorbed and the internal homeostasis is maintained. Now, if there is something wrong with either the whole of the cell as it together or certain channels, that will lead to proximal renal tubular acidosis because bicarbonate is lost in the urine. Okay, so when looking at the specific etiologies of proximal RTA, an autosomal recessive could be due to this NBC1 gene mutation. Something would be due to congenital isolated RTA, which is a little rare entity. So the hallmark of proximal RTA is the reduced threshold for reabsorption of bicarbonate. When the serum bicarbonate concentration increases and approaches the normal, the patients with this proximal RTA will develop increased loss of bicarbonate. And their bicarbonate titration curve is similar to the normal patients, but it is shifted to the left. Isolated proximal RTA, I have never seen even one patient in my life. The reason being, usually it occurs associated with the generalized dysfunction of the proximal tubule, which is also called as Fanconi syndrome. So what is Fanconi syndrome? It is different from Fanconi-Bickel syndrome of aplastic anemia. This is something completely different. So it is Fanconi syndrome. It is named after a pediatrician, Guido Fanconi. He was in Swiss. Tidoni, Debris, and Fanconi described children with renal rickets and glycosurias way back in 1930s. So what is a basic defect? The defect is in the energy production of the proximal tubule, and when the cell does not have any ATP, the cell dies and there will be complete proximal tubular dysfunction, leading to all the classical manifestations of Fanconi's. So the most important presentation these children come to us is growth retardation, that is failure to thrive. Malnutrition, hypokalemia will be there, hypophosphatemia will be there, because as I have mentioned, proximal tubule helps in the reabsorption of phosphate, and metabolic acidosis because bicarbonate is lost, which will all lead to growth retardation, because metabolic, that is homeostasis, along with phosphate, along with potassium is required for the growth. Polyuria, polydipsia, and salt craving, and refractory rickets, that is resistant to vitamin D, associated with nephrocalcinosis, will also be seen. So this polyuria is secondary to osmotic diuresis from the excessive urinary solute losses and the urinary concentrating defect in the collecting tubule due to the chronic hypokalemia can also be seen. So now look at the causes. See, Fanconi syndrome can even present in adulthood also. But when we look at the presentation etiologies in children, specifically, when we say it is Fanconi syndrome, most common cause for Fanconi syndrome in children is cystinosis. That we have to keep in mind. This is the most common, which is later followed by some other disorders like Dent syndrome, Lower syndrome, other mitochondriopathies, galactosemia, and tyrosinemia Wilson's. Whereas in adults, we usually see like with FSGS and nephrotic syndrome, multiple myeloma, Sjogren's, or even post-renal transplantation, this form of proximal renal tubular disorder. So hereditary causes are usually seen in children, and acquired causes are usually seen in adults. As we have already mentioned, since there is a proximal tubular dysfunction, that will cause amino aciduria. That can also cause glycosuria, which usually has no symptoms, but hypophosphatemia can predispose to development of rickets. There will be metabolic acidosis, as we have discussed. Increased sodium loss will lead to hyponatremia, hypotension, and polyuria will be there, and hypokalemia, because all the bicarbonate which is not reabsorbed in the proximal tubule is presented to the distal tubule. And in the distal tubule, to reabsorb this bicarbonate, excessive amount of potassium is secreted out, it will lead to hypokalemia. Hypercalciuria will also be seen, which is by definition more than 4 milligram per kg per day. This is the reason why these children will develop nephrocalcinosis. And associatedly, because proximal tubule also helps in the reabsorption of small low molecular weight proteins, that is for example renin, insulin, other retinol binding protein. All these proteins are usually reabsorbed in the proximal tubule. Now there is a dysfunction in the proximal tubule. So what happens? These proteins are also lost. That will cause some amount of mild proteinuria, but not nephrotic range. And this proteinuria is also called as tubular proteinuria. So what is the treatment? Treatment of the metabolic acidosis is more difficult in proximal RTA. May I know the reason why? Because when we start giving them soda bicarbonate, their serum soda bicarbonate increases, and when the bicarbonate level in the blood increases, it gets leaked off into the urine, and again their serum bicarbonate level goes down. So as we increase the therapeutic dose, there will be increased amount of bicarbonate urea, and hence these children will require usually a very high dose of 10 to 15 milliequivalents per kg of alkali, that is bicarbonate in divided doses. And we have to be really careful, because once we are starting to give these children so much amount of bicarbonate, their potassium level, which is already low, there is a chance that it will fall precipitously and will lead to cardiac failure. That you have to keep in mind. Now coming to the most common cause, cystinosis. Nephropathic cystinosis is also the first treatable lysosomal storage disorder in mankind. There are three different forms. Infantile cystinosis, which is the most common cause. So what happens is this cystine does not get excreted from the lysosomes, and it gets stored in the lysosomes, and excessive increase will cause cell destruction and cell death, leading to proximal tubular cell death and proximal tubule complete dysfunction in the kidney. At presentation, they usually present with failure to thrive. These are all the same signs and symptoms of the proximal renal tubular dysfunction: polyuria, polydipsia, vitamin D resistant rickets, that is hypophosphatemic rickets. These children, when compared to isolated Fanconi's, that is cystinosis, will eventually have progressive renal failure, and due to the accumulation of the cystine crystals in the cornea and the lens, that will lead to photophobia, and other organs, that is thyroid and the skeletal muscles or the smooth muscles, will lead to hypothyroidism and difficulty in deglutition, dysphagia, myopathies also. These corneal crystals are very pathognomonic for this Fanconi's, that is cystinosis, and they are usually present by 16 months or of age by slit lamp examination, and in a slit lamp examination, if they are not present by the age of 2 years, then cystinosis can be essentially ruled out. So these are the typical cystine crystals which are seen on the cornea in the slit lamp examination. These are very pathognomonic for cystinosis. This is a very interesting case. An adult post-transplant patient with cystinosis. She was treated with these drops, cysteamine eye drops. Only I don't know the exact reason why she has taken these eye drops only in the right eye. Can you just observe that the right eye is very clear, whereas the left eye is, the cornea is foggy, cloudy. That means that these cystine crystals get deposited in major tissues of the body, leading to organ dysfunction. Other disease which causes proximal tubular dysfunction is Dent's disease, is an X-linked proximal tubulopathy, which is characterized by low molecular weight proteinuria, hypercalciuria, nephrocalcinosis, nephrolithiasis. It is again usually presentation is in the childhood and adolescent period, and by the age the child is an adult, will eventually lead to nephrocalcinosis and renal failure. So there are no extra renal manifestations, and there is some amount of tubular proteinuria. There is no much treatment for Dent's disease. So we won't be discussing much about Dent's disease because rare things are little rare. This is the classic ultrasound finding of nephrocalcinosis in such scenarios. Hypophosphatemic rickets is important because the proximal tubules helps in the reabsorption of phosphate, but we are not going to discuss this in detail. So coming to the distal RTA, when the distal tubules of the kidney are affected, it causes distal renal tubular acidosis. Again, it is of two types, congenital and acquired. Congenital is usually seen in children. The usual presentation of distal RTA in children is congenital. Acquired causes are seen in adults, post-renal transplantation or autoimmune diseases. All those cases are seen in adults only. Now look at the distal tubule. There is hydrogen secretion into the tubular lumen, and that helps in the formation of ammonia, which is the method by which the acid load in the body is excreted out. Okay. Now there is something wrong with this H+ATPase enzyme or with this channel. This hydrogen ion is not secreted out, and hence that will cause acidosis in the blood, acidemia in the blood, leading to renal tubular acidosis. Now coming to different types of distal RTA, autosomal dominant distal RTA, that is type 1A, is due to this anion exchanger 1 gene mutation, and the autosomal recessive one, which is usually associated with hearing loss, like hearing loss. This is one example where and renal tubular acidosis is associated with hearing loss. Another one is the Bartter syndrome, where also these children can have hearing loss. Okay, so this is autosomal recessive, which is due to H+ATPase enzyme deficiency or genetic mutation over here. And type 1C is usually without hearing loss. So these are the congenital variants of distal RTA. So if the distal nephron is not capable of performing its function, the patient will use the existing buffers in the body to buffer the excessive acid load. So where does this excessive acid come from? From normal metabolism in the body. In children, nearly 2 milliequivalents of acid is produced per day. This has to be buffered in the body. So if that buffering is usually expected in the distal tubule. Now, if there is distal renal tubular disorder leading to distal RTA, so where does this excess acid gets buffered? It gets buffered in the bones leading to rickets. Okay, these children usually present with hyperchloremic metabolic acidosis, that is normal anion gap, associated with polyuria and polydipsia, hypokalemia and nephrocalcinosis. And here the urinary pH will be more than 5.5 because there is something wrong with the acidification of the urine. And calcium excretion is also high, which will lead to nephrocalcinosis. The treatment in such scenarios is giving bicarbonate. So how is bicarbonate available? We all know that bicarbonate was previously, even now it's available as soda mint tablets. These are very economical tablets, but nowadays we also have this syrup nodosis, where 10 ml of this contains nearly 10 milliequivalents of the bicarbonate, that is base, and potassium has to also be replenished. We usually give in the form of K-sit or potrate. So this is the thing which I wanted to emphasize. Identification of the renal tubular acidosis in children is very, very important. The reason being, if we treat them adequately, maintain the serum bicarbonate levels within the normal range, prevent the abnormalities of this acidosis, and maintain the bone structure and prevent nephrocalcinosis, then definitely we can treat these children very well. They'll grow up into very good adults, and the compliance will also increase. Thank you. So that's all from my side. So this was just regarding the approach and a basic information regarding renal tubular acidosis.
Thank you, Dr. Vijay Kiran.
You're welcome, sir.
Thank you, Dr. Vijay Kiran, for enlightening us about different types of renal tubular acidosis, how to keep clinical scenarios and common lab finding, so that we can diagnose early, so that the growth is a very, very important fundamental of the children, which can be taken care. So thank you very much. So over to Dr. Yashowanth Rao, Secretary. Yashowanth Bhaiya.
Yashowanth, I think Yashowanth. Hello, Dr. Yashowanth. Any Dr. Laxman Kumar? Any questions to Dr. Vijay Kiran?
Yeah, not at no questions
in the chat box.
No questions.
Oh, okay.
So Vijay Kiran, I have one question, sir.
Yeah, please.
So yeah, you mentioned some drugs for the causation of RTA.
Yeah.
So what are the drugs which usually causes RTA, so that the practicing pediatricians will know whenever they put up a pen onto the prescription paper? Please highlight the drugs which can lead to the RTA, whether it is proximal or distal.
These are usually the cancer therapeutic agents like cisplatin, which causes more of proximal RTA, ifosfamide, which causes more of distal RTA. But routine practically how prescription which we give usually does not cause all these disorders. Number one, cadmium poisoning, mercury poisoning can also lead to deposition of these heavy metals. So heavy metal poisonings can also cause this different types of renal tubular acidosis. So from our point of view as a pediatrician, I don't think we should be much worried about the drugs which we routinely use.
So there is a question from Chandramouli, doctor. When can an RTA usually diagnosed by age-wise? So that means you have got proximal and distal, or how early we can diagnose as age-wise?
Yeah, that's a very good question. So this paper, can you see it on screen, sir? Yeah. So this paper which we have analyzed of these children with renal tubular acidosis. In this, we also analyzed the latency period from the onset of symptoms and when they were actually diagnosed. There was a gap of nearly 3 years when the symptoms have started and then when they were diagnosed. That is number one. Okay, latency is little higher because they go to the primary care in the their district places. They give some treatment and the parents say that they have mildly improved, or they keep on neglecting and they come to us a little later stage. But maximum by the age of 5 years, these children do present to us.
Okay. So no more questions. Let us go to the next talk. Can we go to next talk, President Ji? Garlapati. Yashowanth. There are no questions in the chat box. Yashowanth.
Hi, Vijay.
Yashowanth.
I think systems are muted, so I think they will need to unmute Laxman Garu.
Yeah, it is. No, because Yashowanth is the controller, sir.
Right.
Laxman, Garlapati.
Yeah, no. Yeah, Dr. Yashowanth is looking after.
Yeah, but he is on a mute mode. He is not listening to us. So he is not listening to us. He is on mute mode. He is the host.
Hello.
Yeah.
Laxman, sir.
Yeah.
Yashowanth.
I have unmuted, sir. And let me introduce Dr. Mehul Shah. He did his MBBS from GS Medical College. Then did his DCH and MD Pediatrics in '93 from Wadia Children's Hospital. Then he did his MD from USA. He went on to do fellowship in American Board and came back to India. I think Dr. Mehul.
Yeah, hello.
Yeah, Mehul. Yeah, good evening, Mehul. Good evening, Mehul ji.
Good evening, Dr. Laxman Garu.
Good evening. Good evening.
Yashwanth and all our senior friends. Dr. Rao Garu is there. I think, thank you, Vijay, for taking us through an approach to a child with suspected renal tubular disorders. I think it will make our part a little easy. I will take further from where Vijay Kiran has left. He has explained to us nicely about the approach to a child with suspected renal tubular disorders, and mainly the proximal renal tubular disorder, mainly renal Fanconi syndrome, distal renal tubular acidosis, and some uncommon causes of renal Fanconi syndrome like Ben's disease. So let me start with the first case over here. It's a 2 months baby girl who was referred for failure to thrive and respiratory infection, rapid breathing. She was born at term with birth weight of 3.5 kilos. Amniotic fluid was reportedly adequate. When she came at 2 months of age, her weight was 3.2 kilos and she appeared dehydrated. So we can see that there was a weight loss. Not only there was no weight gain, but in fact there was weight loss. She had normal fecal genitalia. The urine examination showed a pH of 7.0, specific gravity of 10, and rest of the examination on urine test was negative. It's important to make sure that, especially in the baby girl, the genitalia are normal, because this way we can straight away rule out congenital adrenal hyperplasia. So she had a blood gas done because there's a possibility of a respiratory infection as well. And this showed that she had more of a primary metabolic acidemia 7.08, PCO2 of 80, and bicarbonate of 8.0. So this was a primary metabolic acidemia with some respiratory compensation. Further evaluation showed hypokalemia 1.8, hyperchloremia, and the bicarbonate measured was confirmed to be low, which coincides with the bicarb of 8.0 on the blood gas. So her plasma anion gap over here, which is sodium minus chloride plus bicarbonate. So 123 plus 10 is 133. So 142 minus 133, it is 9. And as was mentioned, this is a normal anion gap, hyperchloremic metabolic acidemia. The most common cause of this scenario is diarrhea. And I think Vijay has already mentioned that the most common cause of hyperchloremic metabolic acidemia in a child is diarrhea, which we can easily rule out based on history. In this child, there was certainly no diarrhea. To further evaluate the etiology of this metabolic acidemia, which is not diarrhea related, we did a urine electrolytes, which showed sodium of 58, chloride of 32, and chloride of 65, and potassium of 32. This is to estimate the urinary anion gap. This is a little different from plasma anion gap, which is sodium minus chloride plus bicarbonate. Here it is positive minus negative. So sodium plus 65. And that is plus 25. So the urinary anion gap basically gives you an idea about the amount of ammonium which is present in the urine. This being positive, meaning chloride is more, which means that there is less of ammonium in the urine. Renal function was normal. Ultrasound did show prominent medullary pyramids like the nephrocalcinosis, which Vijay Kiran had shown in one of his slides. So I think here the case is very easy to diagnose. It wasn't a respiratory infection. The rapid breathing was the respiratory compensation for metabolic acidemia. This child has got straightforward distal renal tubular acidosis. So the treatment is to start with oral potassium chloride. Whenever a child with metabolic acidemia and hypokalemia presents to us, our first objective is to correct the hypokalemia, not be in a rush to correct the metabolic acidemia. There are two situations where we should not treat metabolic acidemia. This is one scenario, hypokalemia with metabolic acidemia and hypokalemia in a child with acidemia and diabetes ketoacidosis. Never give bicarbonate or insulin until the potassium is corrected. Because if we correct the metabolic acidemia, potassium is pushed back into the intracellular compartment, precipitating further drop in potassium and cardiac arrhythmias. So the first objective is to correct the hypokalemia for 3 to 4 days. Let the potassium come up to more than 3.2 or 3.5 and then start correcting metabolic acidemia. The child will not die because of metabolic acidemia, but child can have a cardiac arrhythmia, cardiac arrest, and can die because of acute drop in plasma potassium. So the learning points is in a small child presenting with respiratory quote unquote infection, it's not always a pulmonary pathology. It could be acidotic breathing. Please look at the blood gas to see whether there is metabolic acidemia or respiratory acidemia. And also importantly, this child did not have weight gain at 2 months of age. So all these factors would suggest that there is something more than just the respiratory complaint with which the child has presented to us. Conversely, this is another child who presented at 5 years of age with failure to gain weight, increasing weakness, inability to ambulate for the past 6 months. She was apparently fine for the 3 to 4 years of age, but the symptoms started since 4 to 4.5 years. On inquiry, she did have history of polyuria, nocturia, polydipsia, and constipation. She had growth retardation, blood pressure was lowish, there was generalized hypertonia, and she had Janu Varam, rickets with Janu Varam. Urine had a low specific gravity, pH was 5.0, trace protein and no sugar. Please remember, in a dilute sample, trace protein is significant. Blood gas showed mild metabolic acidemia with pH of 7.28. bicarbonate of 17. Again, there was hypokalemia, hyperchloremia, and low bicarbonate. Plasma anion gap 141 minus 115 plus 16. This is 131. So 141 minus 131, anion gap is 10. So it's a normal anion gap, hyperchloremic metabolic acidemia with mild metabolic acidemia. As compared to the other child with a pH of 7.06, this child has got only mild metabolic acidemia. Phosphorus is low, 2.7. Alkaline phosphatase is high. Renal parameters were normal. And urinary anion gap was minus 15 over here as compared to plus 25 in the previous child. She had normal urinary calcium creatinine ratio and the fractional excretion of phosphate was 25%. This is important because the serum phosphorus was low. We need to know, is this low because of renal phosphate wasting, because of proximal tubular disorder, or was it because of malnutrition? A renal ultrasound over here did not show nephrocalcinosis. So this child, if we look back, has got features of generalized proximal tubular disorder, including mild proteinuria, hypokalemia, metabolic acidemia, hypophosphatemia, and rickets. So failure to thrive with weakness, with rickets, hypokalemia, normal anion gap metabolic acidemia of mild type, low serum phosphorus, acidic urine pH. Again, as Vijay Kiran has mentioned, in children with proximal renal tubular acidosis, as soon as the bicarbonate drops below the threshold value at which the proximal tubule will reabsorb, there is no loss of further bicarbonate and the distal renal tubule will be able to acidify the urine adequately, and hence the urine pH will be less than 5.5 when the plasma bicarbonate is less than the threshold of say 16 or 18. Mild proteinuria, trace protein with a dilute sample is significant, and negative urinary anion gap. So all these features put together would say that this child has got a renal Fanconi syndrome. This is much more difficult than distal renal tubular acidosis, as was mentioned by Vijay Kiran. I think we can treat 99 children with distal renal tubular acidosis confidently and happily, but it's very difficult to treat one child with renal Fanconi syndrome. They need very high amounts of bicarbonate. They start losing more potassium once we treat them. They need oral potassium chloride. They need phosphate and active form of vitamin D3 to correct their rickets. So what are the major differences between distal RTA and proximal RTA? Both these groups of children would present with failure to thrive, polyuria, polydipsia, and on evaluation, they will have hypokalemia, hyperchloremic, normal anion gap metabolic acidosis, and a dilute urine with low specific gravity less than 1010. So how do we differentiate? I think simple parameters which will help us differentiate between distal and proximal RTA. What is the urine pH? First thing, looking at a complete urine examination can give us a lot of information. Many times, unfortunately, in the laboratories, we don't get the pH, we don't get the specific gravity. And these are the two simple parameters which can guide us as to what the child may be having. Urine pH more than 6.0, distal nephron acidification defect. Urine pH less than 6.0 in presence of metabolic acidemia would tell us that the distal nephron is working normally. Is there any proteinuria, glucosuria? In case if it is there, we would think about proximal tubular dysfunction. What is the urinary anion gap? Normal being 0 plus minus 5. So if the urinary anion gap is more than 5, it means there is no ammonia. Positive anion gap means there is no ammonia, which means there is a distal nephron hydrogen secretory defect. Urinary anion gap which is negative, like in the second child, which would mean that the distal nephron is normally working and we should be thinking about proximal tubular dysfunction. What is the severity of metabolic acidemia? So these are the three urinary parameters. Blood pH. Usually children with distal RTA will present with profound metabolic acidemia. pH is usually less than 7.2, whereas children with proximal RTA will stabilize their pH around 7.25 to 7.30. Because as soon as the pH starts going below 7.25 and the bicarb drops below 16, the proximal tubule has enough machinery to reabsorb the filtered bicarbonate, and hence the pH does not drop below 7.25. Is there any hypercalciuria? Children with distal RTA often have hypercalciuria and often have nephrocalcinosis, which is usually not seen in children with proximal RTA or renal fine-coolness syndrome. In fact, they may have hypophosphatemic rickets because there is a defect in reabsorption of phosphate in the proximal tubule. Let's move on to a third case. It's a 2-month boy referred for quote-unquote metabolic disorder. This is a boy which I have been seeing for the last 18 years. He was born at 35 weeks with birth weight of 2.3 kilos. Mother had history of polyhydramnios with AFI of 28 centimeters at 35 weeks. There was history of failure to thrive, intermittent vomiting, associated with polyuria and severe constipation. On examination, he had inadequate weight gain. He was dehydrated with triangular faces and was hypotonic. Again, look at the urine specific gravity, 1005, which would make you think that there is a defect in renal concentrating ability. And that is one of the features of most patients with renal tubular disorder. A low specific gravity gives us a lot of information. And this was a child, the photo was taken about 6 months after treatment. We can see that he's got little sunken eyes, he's got a triangular face, and if we can, believe me, this is something what we call as a Barter phenotype. So many times when we look at the children's face, especially when they first come to us, it gives us a clue as to what could be the underlying renal tubular disorder. This was his photograph when he was around 2.5 years of age. Now he's about 20 years of age and his height is 175 centimeters. So certainly some children with Barter syndrome, they do extremely well. They have difficult period in the first 2, 3, 5 years of age, but they tend to do better. His evaluation showed that he had metabolic alkalosis, 7.56 with bicarb of 45, hyponatremia, hypochloremia, severe hypochloremia, and bicarb was high. So low sodium, low potassium, low chloride. Rest of the parameters were normal. And here again, a set of urinary electrolytes is going to be very helpful to differentiate this situation from a common cause of this presentation, and which is vomiting. So here the urinary chloride was very high, and urinary chloride more than 20 would tell us that the kidneys are losing sodium chloride and it is not GI system which is losing the chloride. Renal ultrasound did not show any nephrocalcinosis. All children with Barter syndrome may not have nephrocalcinosis, but if it is there, it may help us. So the diagnosis here is Barter syndrome. It was difficult to treat him. He required oral salt and then ibuprofen followed by COX-2 inhibitors and a good amount of potassium chloride. He's off all the medications except for potassium chloride as of now. A close differential over here could be pyloric stenosis. We have a 2-month boy presenting with failure to thrive, vomiting, polyuria, hypokalemia, hypochloremia, metabolic alkalosis. Please think about vomiting as the most common cause of this metabolic disorder. Barter syndrome is there, but common things, as was discussed by Vijay Kiran also, we should keep that first in mind. Factors which go against pyloric stenosis in this child is, 1, he had polyhydramnios. Polyhydramnios would mean fetal polyuria. Fetal polyuria would mean the child was losing a lot of electrolytes during the fetal life. A child with pyloric stenosis will not have polyhydramnios. Usually the amniotic fluid is normal. And because the kidneys are normal in a child with pyloric stenosis, they will try to conserve as much of sodium chloride as positive. And the specific gravity is going to be more than 1020. And hence, again reinforcing, looking at simple parameters on a complete urine examination can give us a lot of information as to what could be the possible etiology. Finally, if there's a doubt, we look at the urinary electrolytes. Kidneys are trying to conserve what is being lost from some other sources, and the urinary chloride estimation is going to be less than 20 milligrams per liter as compared to 112, which was there in this child. Moving on to a fourth case, which is a 3-year boy referred for evaluation of developmental delay and question cerebral palsy. He had 2 episodes of generalized seizures at 3 to 4 months of age, used to void large amounts of urine every 10 to 15 minutes, including at night time, meaning he had nocturia at 3 years. Drinks about 3 liters of diluted milk per day, which comes to about 300 mL per kg per day, which is polydipsia. And he also had severe constipation. So going back into the history, he had seizures, he had nocturia, he had polydipsia, and he had severe constipation. So a child with a primary CNS disorder could have this symptoms because of central diabetes insipidus, but could this be a renal problem? And again, this was a child at 3 years of age. We can see he's so malnourished, he's got a sunken eyes, and he requires support to sit. Weight was only 8 kilos, height was 75 centimeters. Look at the facial features, and he had generalized hypotonia. A child with cerebral palsy, we would expect him or her to have some amount of hypertonia rather than hypotonia. His investigation showed an isosthenuric complete urine examination. pH was normal, blood gas was normal. Look at the electrolytes, essentially normal. Calcium was normal. Kidney function tests were normal. So what are we dealing with? Essentially, his reports are unremarkable, except that he's got a low specific gravity. Are we missing something over here? Is this acidosis? No. Is this alkalosis? No. So we have ruled out RTA. We have ruled out Bartter syndrome. We have ruled out chronic kidney disease because of hypodysplasia or because of PUB. So we have ruled out 4 common causes of renal causes of failure to thrive. We did urine electrolytes because he had got significant polyuria and polydipsia. And for him, this was on the lower side. If you look at the previous 2 cases, they were losing a lot of sodium chloride in the urine. And these parameters were like 40, 50, and 100. Whereas here, the electrolytes are less than 20 milliequivalents per liter, which are in a very, very low concentration. Ultrasound showed bilateral hydroureteronephrosis with large bladder. We went ahead and did an MCG to make sure there is no reflux, which was, and no PUB, and there was neither reflux nor PUB. Hence, we obtained urine osmolality, and that was very low. So urine osmolality was 75 milliosmoles per kilo of water, and the diagnosis here is diabetes insipidus. Now the question is, what is the type of diabetes insipidus? Is it central or is it nephrogenic? So diabetes insipidus, he was losing more water in the urine, and hence his electrolytes were diluted over here. We did a modified water deprivation test and DDAVP challenge. There was no response to DDAVP, meaning if there was a central DI, the child's urinary concentration would have improved after we give an exogenous DDAVP. This child continued to have low specific gravity, low urine osmolality despite DDAVP. So he had a primary nephrogenic diabetes insipidus with an acquired mental subnormality. Why acquired? Because he had repeated episodes of hypernatremic dehydration, which was causing the seizures, and that recurrent episodes affected his mental development. So the learning points over here are, friends, seizures, as has been discussed with our friends, think about electrolyte disturbances, think about hypertension as renal contributing factors to seizures. Cerebral palsy or development delay was because of recurrent episodes of hypernatremic dehydration and a secondary CNS insult. Always obtain electrolytes along with blood sugar and blood pressure measurement in a child with failure to thrive with seizures. Simple to obtain, gives us a lot of information. I'm sure the question in the minds of everyone would be, this child had a normal plasma sodium. So why did we think about diabetes insipidus? Would not we expect plasma sodium to be high? But friends, the plasma sodium was normal because he was thirsty and he was able to take in a lot of water. With the normal mental development, the intake of water is going to prevent hypernatremia. When he was less than 1 year of age, the parents did not recognize that his crying episodes were because of thirst. He was not able to take water, and hence he was getting hypernatremic dehydration. As he grew and as he was able to communicate, he was drinking more water. So children who have got a normal mental status and have diabetes insipidus will have normal plasma sodium concentration. It's only when they have mental subnormality, or if they are in the ICU, or if they do not have access to water, that's the time when sodium level will go up. So normal sodium level is expected in children with DI as long as the child has free access to water, mentally and physically. I would like to end with one case over here. It's a 6 years girl who had 3 episodes of severe weakness over past 2 years. In between the episodes, she's well. Evaluation showed potassium of 1.6 to 2.3. Each time she was treated with IV and oral potassium chloride and she improved. So I'm sure there is no differential over here. This child has got recurrent episodes of hypokalemic periodic paralysis. Diagnosed, treated, recovered. There are no doubts about this. Question is, this has been happening for the past 2 years and each time she comes back. We need to keep on asking questions to ourselves. Why is this child having recurrent episodes of hypokalemic periodic paralysis? Let's go back into the history. Does this child have polyuria, polydipsia and constipation? How is the child's growth? We should not label this child as having a genetic cause of hypokalemic periodic paralysis until we have ruled out other causes, and that's what we are going to come to. How about her urine examination? Again, it showed a low specific gravity, pH of 6.5, no protein, no sugar, because are we dealing with a child with renal Fanconi syndrome, Bartter syndrome or something else, which can have hypokalemia as one of its features? Did we do a blood gas on this child? The pH was 7.25 and bicarbonate was 15. Is this expected in a child with a genetic cause of hypokalemic periodic paralysis? No. In a child with genetic cause of hypokalemic periodic paralysis, the blood gas is going to be fine and the potassium in between the episodes should be completely normal. Those children will not have polyuria, they will not have polydipsia, and more importantly, their growth is going to be normal. This child had increased urinary potassium losses of 55 milliequivalents per liter. And if you look at the urinary anion gap, 65 plus 55, it is 120 minus 80. So it's plus 40, meaning there's a defect over here. Ultrasound showed echogenic pyramids. So now the revised diagnosis, friends, the child does have hypokalemic periodic paralysis, but it's not the genetic cause. It is due to distal renal tubular acidosis. So the learning points over here, hypokalemic periodic paralysis, inherited types to be considered in a well-grown child who does not have any acid-base disorder. So history, plotting of the growth parameters and at least doing a blood gas is essential in a child who comes with recurrent episodes of hypokalemia. Always obtain blood gas, urine electrolytes and renal ultrasound in a child with periodic paralysis. I think is that okay or can I carry on with one case, Dr. Rao?
Yeah, please continue, sir. Please continue.
Okay, okay.
Thank you.
This is a 9 months boy who presented with frequent urination, increased intake of water and irritability since 5 months of age. Upon inquiry, he was on breastfeeds until 5 months of age and is currently on formula feeds with intake of 120 ml of formula milk 7 to 8 times a day, plus 100 ml of water 3 to 4 times a day, plus solid foods. So straight away, looking into the history, this is a bit too much for the small child. The good thing is the boy is usually dry at night and has an occasional bottle feed 2 to 3 times in a week. He was born at term, there was no polyhydramnios, and his mental and physical development was normal. And these are the pictures of a similar looking 9-month-old child, which we can see is quite playful, well grown, looks euvolemic. No positive findings on examination, weight of 8.5, which is quite appropriate for a 9-month-old child. If we estimate his oral intake by the measurement which the parent has given, he's got 840 ml of milk plus 400 ml of water, which comes to 1240 ml, which is more than 2 times the upper limit of physiological fluid intake of 1500 ml per meter square per day. But again, please look at the specific gravity, 1020, normal pH, no protein, no sugar. So what are we dealing with over here? Is this child, I'm sorry, I'm missing one slide over here. So this child is essentially having a compulsive or forced intake of liquids, which is causing the polyuria during the daytime. At nighttime, he is not drinking enough milk, he is not passing enough urine, he is well grown, and he has got a normal specific gravity. So he does not have a renal tubular disorder. It is more of a faulty feeding. Maybe the parents wanted him to take a lot of feeds and hence he was passing more urine. And the final case over here, all children with polyuria polydipsia need not have renal tubular disorder, or for that matter, they did not have any problem. We need to look at the other causes as well, as in first few slides Vijay Kiran had mentioned. Common things should be thought about, but in a child who is having failure to thrive, please think about renal problems. 2 years boy presented with failure to thrive, polyuria, polydipsia, recurrent fevers. Birth weight was 2.6, amniotic fluid was reduced, he was malnourished, he had signs of rickets. Specific gravity of 10-10, trace protein. So presentation is quite common like the other children, except here the amniotic fluid was reduced. Most children with Bartter syndrome or with diabetes insipidus presenting in the first few months of life would have polyhydramnios. Oligohydramnios is usually not a feature of renal tubular disorders presenting in the first year of life. He had metabolic acidemia, mild hyperkalemia. Plasma NN gap was elevated over here. 136 minus 18 is plus 18. So this is a high NN gap metabolic acidosis. Creatinine of 1.0 is high for a 2 years boy. Ultrasound showed bilateral hydronephrosis. Should we do an MCUG? Yes, we should always do an MCUG because this child has had recurrent fevers, has got failure to thrive, oligohydramnios, and bilateral hydronephrosis. How is the urinary stream? And what is the MCUG? And this is what the MCUG showed. He had a classical posterior urethral valves with bilateral high-grade reflux. So he was having polyuria polydipsia because of renal dysplasia, and that is why he was having a concentrating defect and polyuria, which caused the polydipsia. So friends, CKD in this child was because of obstructive uropathy. Suppose if there was no hydronephrosis and the kidneys were small in size, similar features could be because of a primary hypodysplastic kidneys. So a child with CKD can present with failure to thrive, polyuria and polydipsia. We think about renal tubulopathy when the renal function is normal. So if there is a elevated urea creatinine not explained by dehydration, we should think about renal tubular disorder. If the elevated renal parameters are there, think about other causes of renal disease. I think I would like to stop over here, and these are the things which have already been discussed by Vijay Kiran. Suspect renal tubular disorders in a child with failure to thrive, polyuria, polydipsia, after excluding renal failure. Please start with a detailed history, including birth weight and amniotic fluid index. They give us a lot of information before focusing our physical examination findings on growth, on blood pressure, palpable bladder, genitalia in a small child, hyperpigmentation, and rickets. Investigations to begin with a complete urine examination. A blood gas, usually a venous blood gas, may be sufficient. Electrolytes, creatinine, and ultrasound, which can be done in almost any district now. Diagnosis is usually easily made. Treatment is effective, economical. It decreases the morbidity and reduces the risk of progressive CKD. Thank you so much, and Vijay Kiran and I are happy to take any questions. Or
yeah, thank you, Mehul ji, because you have been from yesterday night CKD2 case scenarios. Now it is like a 2020 match is going on. So between PATS and TCB IAP. Anyway, thank you very much from PATS.
No, it's
for the important the clinical features we have to keep in mind that any failure to thrive, history of polydipsia, the polyuria, yes. Then the history of birth weight, then the routine examination is very, very important in the form of electrolytes, urine examination, and which will go a long way to prevent the chronic renal failure of the CKD in children of our community. And on behalf of PATS as well as IAP, we would like to thank you for making us the most important information on the case scenarios. And both of you, Vijay Kiran as well as you, has taken the time to enlighten us in this COVID-19 pandemic, because we are in the evening. Almost we would like to see in the past IPL matches, but now there is hypervenosis is there in the throughout India as well as in the states. So thank you very much.
Thank you.
Now I request, there are few questions are there for you.
Okay.
And one is what Dr. Chandramouli wants to know, at what specific
Sir,
gravity
there are some questions, sir.
Yeah.
Dr. Chandramouli wants to ask some question.
Yes, please. Yes, please.
Yeah. I'm reading.
Doctor.
I'm reading Chandramouli's question. At what specific gravity we should suspect diabetic insipidus in a small child who complains of frequent urination in a normal growing child? Can we suspect diabetic insipidus? Mehul?
No, I think if a child is growing well, the possibility of any renal tubular disorder is going to be very, very low. And we would not think about a renal tubular disorder, because patients who have got renal tubulopathy, be it RTA or Bartter syndrome or diabetes insipidus, because of polyuria, they will have polyuria, and most of the time they will be drinking water to the extent that the stomach is filled with water and they won't be able to drink enough milk, and hence the calorie and the protein intake is going to be less, and hence they are going to have failure to thrive. A child who is growing well and has got polyuria, we need to think about feeding habits. So coming to the answer, if the specific gravity is less than 1010, which is 1005 or 1010, we need to think about renal tubular disorder. That does not mean that always 1010 or 1005 would mean it's a renal tubular disorder. Suppose if the mother has just fed the baby 150 ml of diluted milk, maybe the preparation of formula is not proper, it's a dilute milk which the mother is giving. In that situation, the urine is going to have a appropriately dilute urine. So we need to collect a first morning sample by keeping a minicom bag and collecting a first morning sample when the child has not been fed for about 5 to 6 hours. In this situation, if the specific gravity is 10, 15 or more, it tells us that the renal concentrating ability is adequate and the child's growing well. We don't need to do any more investigation. If there is a doubt and the parents are anxious that my child is still having a lot of urine, is drinking a lot of liquids, all we need to do is urine osmolality. If that's available, if that's not available, a check of electrolytes and a blood gas. But a complete urine examination followed by urine osmolality if required, and a venous blood gas and electrolytes.
Yeah, thank you. One more question is that in renal stones, is there any effect of tardy? Because in this part of South India, a lot of people will take a toddy in the summer or in the winter also throughout the year. Correct. So does it have any effect on clearance of renal stones? Somebody wanted to know it from you.
I think it's a good question to be honest. So I don't know the answer. I really don't know. Probably even if our friend can answer. I really don't know the exact constituents of the toddy. I know people are taking, especially in a lot of places. But I think it's a good question. I will need to check it myself about the.
Yeah, I think we should. I think we should have a study on.
Yes. But I think unless it has got lot of citrate in it, and maybe along with that, if they are taking a large quantity and it's diluting the urine, maybe the dilution factor of the citrate, if it's there, it would help. But otherwise, it should not help. Because what helps the renal stones is the water intake and the intake of fruits and vegetables, which provide citrate, which is a natural chelator of calcium and oxalate in the urine.
Yeah,
Thank
you. This question is from Sudhakar Chiluka.
Okay. Good point.
Okay. Our president of PATS wants to know that in Bartter's syndrome, is it ibuprofen or indomethacin is better? Which is better?
Actually, there have not been a lot of studies comparing the different types of non-specific COX inhibitors. What we are referring to is ibuprofen or indomethacin. Most Western countries had been using indomethacin because it's available in a suspension form. In our country and a lot of other Asian countries, because indomethacin is not available in a solution form, in a syrup form, we either open up the capsule, indomethacin, or powder it and then mix it in water and give. Because ibuprofen is available as a syrup suspension form, we have been using ibuprofen in small children. Older children, we can use indomethacin. Some of us have used indomethacin even in 2 to 3 months of age. So I don't think there is a pharmacological difference between the two, because both of them act by inhibiting the prostaglandin production in the kidneys. So I think there are no studies, and it's the convenience of using a syrup form in a small child. We use ibuprofen. If I can just take one more minute, in our older children.
Okay.
Thank you very much, Mehul. Sir,
and
my question to Mehul Shah, sir.
Yeah.
My question to Dr. Mehul Shah.
Yes.
Hello.
Yeah, I'm listening.
Sir.
Yeah, listening.
Please mention. I think it's been muted.
So thank you once again. Yeah.
Sir, hypokalemic periodic paralysis, it most of the time presents as isokalemic and hyperkalemic, and there are certain precipitating items which precipitate it in adolescence.
Absolutely.
Why is it so?
See, I think that's a very good point. The 2 or 3 major precipitating factors for hypokalemic periodic paralysis are intake of a heavy meal containing rice or biryani. Especially these children who have gone to some function the previous night and they have had a large amount of rice-based diet. The rice, which is carbohydrate-based diet substrate, is going to increase the blood sugar level. That blood sugar level is going to stimulate the insulin production. Insulin is going to push the potassium from extracellular to intracellular compartment. So it is a high carbohydrate meal is usually what stimulates insulin and pushes the potassium from ECF to ICF, causing a sudden shift and disturbance in the resting membrane potential. So that is one reason. Second thing is, if the child has got lot of vomiting or loose motions, and that's another reason why already the plasma potassium is low or the plasma potassium is normal and there is a loss from other sources. The third reason is what has been described is a lot of physical activity in terms of exercises. Exercises is going to increase the circulation of catecholamines, and insulin and catecholamines are 2 hormones which even at basal level are required to keep the potassium in check, and they push potassium from extracellular compartment to intracellular compartment. So I think these are the 3 factors which can bring about an hypokalemic periodic paralysis.
Yeah, thank you very much, sir.
There are seniors in the audience.
Rangaya sir from USA.
Yes, Dr.
Yeah, Rangaya sir from USA. Rangaya sir from USA.
You'll need to unmute.
Yeah, I'm unmuting him, sir. I'm unmuting him. Yeah, 1 minute. Yeah, I'm unmuting him. Yeah,
team.
I've unmuted him, sir.
Yes.
Congratulations for PATS team, Dr. Laxman, Garlapati, and Yashowanth, and Yashowanth Rao, and moderator today's Laxman Kumar, and eminent speakers, Dr. Mehul Shah and Vijay Kiran. Very useful, especially pediatric intensive care units, doctors, and PGs. Congratulating with you, sir.
శ్రేయక్ అయిపోయింది అంటే మొన్న ఒక్క రోజు ఉన్నింది ఆన్లైన్ తర్వాత క్లాసెస్ పొద్దునే క్లాసెస్ 8 గంటల నుంచి
Dr. Yashowanth?
ఉందేమో
Dr. Yashowanth?
Shah, we conclude, sir.
అసలు
Audible?
వర్క్ అవన్నీ ఆన్లైన్ ఇస్తున్నారు.
Venkatesh Rao wants a question.
Congratulations both the speakers, Vijay Kumar and Mehul sir.
అంటే అది ఆన్లైన్ చేసి పంపించాలమ్మా పార్సలే కూడా.
Not able to hear you, Dr. Rao garu.
Yeah.
ఇది ఎక్కువ ఉండదు శ్రేయాది.
Dr. Yashwanth? No. Hello.
Yeah.
Dr. Yashwanth?
Yeah, sir.
ఆల్రెడీ ఫీజు అన్ని పే చేశారు. పే చేద్దాం
ఎవరో చేస్తున్నారు వాళ్ళు.
Yeah, sir.
Hello, Yashwanth.
Go ahead.
వస్తున్నాయా పాలు పట్టిస్తున్నారా పెడుతున్నారా ఎప్పుడు ఇచ్చిరు అప్పటి నుంచి అట్లనే అవుతుంది ఆయన తాగుతారా తాగినా
Sir, you can carry on, sir.
కూర్చోడం మళ్ళీ అని తెలియదు కదా బేబీ ఎంత
Side talk is going on.
Chandramani, sir.
ఇస్తున్నారు కదా కొంచెం తాగుతుంది కదా బేబీ అడుకున్నా కూడా ఇట్లా
Yeah, sir. You may go ahead. Unmute.
Yeah, please, Ranga sir.
Yeah. Yes, sir. Chandramani, sir, and Ranga, sir.
See, Dr. Mehul Shah, one question to you. There is usually when they do a complete urine examination in a newborn child,
Yes.
people sometimes diagnose excessively urinary tract infection.
Right.
Because they cannot collect properly.
Yes.
And I have experienced several times this problem. When a dehydrated child comes,
Yes.
they do a CRP, they see a CUV, and some persons are saying they start antibiotics, they send culture,
Right.
and lot of inconvenience to the child because they keep an IV, unnecessary antibiotic. Child is well active, clinically well. So please explain at what point they should, how do they see the urine examination? Probably large audience are there now in our group.
Right.
You may please clarify everything.
I think that's very important. I think there has to be a balance between investigations, over investigations, and under investigation. So first of all, I think the clinical scenario should be kept in mind. Why has the family brought the child to us, and are we expecting some kind of infection either in the kidney or elsewhere? Do we need to investigate further? So if there is a clinical suspicion, and if need be, I think certainly a complete urine examination can be collected by a bag sample or a clean cache. But if a urine culture, if there is a strong suspicion of urine infection, I would strongly suggest that in a small child, less than 1 year of age, you should either do a catheter sample of urine, which is the best way to collect urine quickly, or slightly older children, about 3 months of age, we can do a suprapubic bladder aspiration. It's a very, very simple procedure to collect a sample of urine, 2 ml of urine from the bladder suprapubically. So if we collect the sample by a minicom bag, which is what is in most scenarios because of collection by the family, we often get in the sample and we get a positive report. So I think the urine by the minicom sample, it is helpful only if it comes back negative. If it comes back positive, it usually means it's a contamination. We need to have done a catheter sample or a suprapubic aspirin. I think that is second. And third thing is there are two groups of thoughts regarding the urine pus cells. One school says less than 5 pus cells is within reference range, and one school says that even up to 10 pus cells could be considered in the reference range. So I think that is a debatable point over here. But if the child has got plenty of pus cells, meaning more than 50 WBCs per high power field, we need to think about a urinary tract infection. But if they are borderline 10 to 12 pus cells, I think, which we often get, it's very difficult to say. We need to correlate with the clinical background.
Yeah, Dr. Arjun wants to have a doubt. Dr. Arjun. Dr. Arjun. Dr. Arjun. You don't have any questions. Okay. So now I hand over the proceeding to our secretary, Dr. Yashowanth Rao, as well as the president of PATS,
Yeah.
Garlapati.
So, yeah, I'm audible, Laxman? I'm audible?
Yeah.
Yeah. On behalf of PATS,
Yes,
I thank both
you're audible, sir.
Yeah, on behalf of PATS, I thank both the speakers who made it very simple understanding RTAs, and the case scenarios were very excellent. The doubts were cleared very well by both the speakers. And over to Dr. Yashowanth for a concluding note.
Sir, I thank Dr. Vijay Kiran, who had come within 48 hours of my request. And definitely Mehul Shah, sir. He's always there for us whenever we request him. So he made the RTS as simple as possible. Both have done their work justice. Approached by our Vijay Kiran sir and Mehul Shah sir, as usual. He has summed up everything in 7 short scenarios. And both the talks are useful. And from now onwards, I request all our pediatric friends, if they have certain things like when you have suspicion of failure to thrive, polyuria, polydipsia, after having basically investigated, kindly refer to either NIMMS or Dr. Mehul Shah so that we pick up, and we will do something to do a registry for renal tubular acidosis and rickets. So it goes in a long way in our area. I would definitely request Dr. Mehul Shah, why more number of cases of RTA are there towards Nalgonda? Is there anything associated with
fluoride?
Fluoride? Only fluoride or any other thing, sir? Mehul Shah, sir? Dr. Mehul?
Not there.
Sir has left. Vijay Kiran?
Just unmute.
Yeah.
You have to
unmuted.
Yeah. Unmute.
Dr. Mehul Shah, sir, you have to unmute yourself.
Yeah,
unmute him.
Unmuting.
Yeah, he's on mute mode. It's related to fluoride, because fluoride should per se not cause RTA. It does not accumulate in the proximal tubular cells, unlike the other heavy metals like mercury, cadmium, and lead, which Vijay Kiran mentioned. But certainly the increased frequency of consanguineous marriage in certain parts of our country is contributing to prevalence of inherited conditions more in certain pockets of our country. And I think that's one of the factors. Consanguinity. I don't know, Vijay Kiran.
Anything to be added?
Kiran,
anything to be added by Vijay Kiran?
Yeah, Vijay Kiran.
Sir, my opinion is that fluoride has been blamed for many other things, more than what it actually deserves. When we look at the adult data, we get a lot of cases from Nalgonda, which are CA and CKDs also. It's just not renal tubular acidosis or a particular disease, but most of all the kidney diseases, these belts are very much famous for. Even another belt is the Nirmal, Adilabad and Nizamabad, the northern belt also. I really don't know the reason. We just have to do further research to prove all these things. But something like Mesoamerican nephropathy or dehydration, recurrent dehydrations, high salt diet, NSAID usage, all these things are contributing. I think so.
Sir, Vijay Kiran sir, I request you to at least give us some data so that we can sensitize our pediatricians to send such cases and start some registry on behalf of PATS so that we pick on the cases and do justice to the patients. Just give us some data, last year data, where from the cases are coming so that we can alert our pediatricians that so and so cases, please do investigate and do justice to the patient.
Sure,
Thank you, sir.
Sure. Thank you.
Thank you so much. I thank Vijay Kiran, Dr. Mehul Shah, our Laxman sir, past president Laxman Garlapati, Dr. Rajiv Prasad, who had participated from Surat, Shailesh Mathur, Dr. Rangaya, senior most one from USA, Dr. Chandramouli, one and all, for having done and participated in this program. Thank you, one and all. Please leave the meeting. Please leave the meeting.
Thank you.
For security reasons. Laxman Bhaiya. Hello, sir. Rangaya sab.